Very good evening to all my dear MOS members and the ophthalmic fraternity who have joined. Today we have a very interesting webinar. Well, it's everybody's need. A lot of individual practitioners and the MOS members did call me and asked me, why are you not having something on NABH accreditation? So here we are with the experts. We have one of the best faculties who are there with us, Dr. Nirmal Frederick, a good friend of mine, and an NABH assessor. He is the most wanted person in this for the NABH. And we have with us the panelists, Dr. Gagan Dudeja and Dr. Kumar Murugesan, who is going to join in another 5-10 minutes. And Dr. Sucheta Kulkarni, the medical director of H.V. Desai Hospital. Dr. Gagan Dudeja and Dr. Kumaran are tied up with Dr. Nirmal Frederick for the NABH accreditation. So friends, it's going to be a fantastic session. We have with us an expert moderator, Dr. Varsha Puranik. She has been part of getting the H.V. Desai with NABH accreditation. She was the secretary of that committee. And here we are, she's going to moderate the session. She's going to introduce each one of you. At the end of the session, you're going to be enriched with how to go about with the NABH accreditation, especially for the individual practitioners. It's very difficult. And the points we covered, how and why you should do it. There are lots of questions which need to be answered. And here we have the expert faculty. So I welcome all the faculty, Dr. Nirmal, Dr. Gagan Dudeja, Dr. Sucheta Kulkarni, and of course, Dr. Kumar is going to join us, and Dr. Varsha. Over to you for moderation.
Yeah. Am I audible, sir?
Yeah, very much.
Yeah, very much.
Yeah. Good evening to all. And thank you, sir, for such a nice introduction. Is my screen visible, sir?
Yeah, put it on the screen.
Yes.
Share mode.
Yeah. So I welcome all of you to the webinar on benefits of NABH accreditation for the individual practitioner. As we all know, the National Accreditation Board for Hospital and Healthcare Provider is a constituent board of Quality Council of India set up to establish and operate the accreditation program for the health organization. It helps to streamline all the processes at one shot, and it also helps organization to be safe in the court of law. And to give deep knowledge about this, we have eminent speaker Dr. Nirmal Frederick, sir. He is a chief eye surgeon and medical director at the Nirmal's Eye Hospital. He is also a principal assessor of national and international accreditation. He is a member secretary of NABH Eye Care Standard and iBank accreditation. To his credit, he has more than 30 publications, 12 book chapters, and 5 books as an author. He is also a author of NABH Eye Care Standard and NABH Guidebook to the Eye Care. He has received many awards and oration, including the prestigious Dr. Joseph Oration Award, and also he has received the prestigious AIOS P.K. Natarajan Award for the Best Hospital Administration. So I welcome you, sir.
Thank you.
Apart from the Nirmal Frederick, sir, we have expert panelists like Dr. Gagan Dudeja, sir. He is a head of oculoplasty and ocular oncology at Narayana Netralaya, Bangalore, and he is also the in charge of retinoblastoma services. He is a principal assessor with NABH and Quality Council of India, and he is also a member in a member expert group on the eye care standard. Our next panelist is Dr. Suchita ma'am. She is a medical director at H.V. Desai Eye Hospital and also the head of retina department and ROP services. She has more than 42 publications to her credit. She has received many national and regional awards, including a special felicitation by the Queen Elizabeth at Buckingham Palace for her work in ROP. And our third panelist is Dr. Kumaran M. Sir. He is a chief surgeon and director of Kumaran Eye Specialty Center. So with these, we are very fortunate to have such an expert panelist and speaker to give us a knowledge about the NABH. Over to you, sir.
Welcome, Dr. Nirmal Frederick. Just to, I would
Thank
just,
you, Dr. Varsha. Yes, Dr. Jignesh.
yeah, just would like to welcome my honorary secretary, Dr. Rajesh Joshi, the backbone of MOS. He is also joined. Welcome, Dr. Rajesh. I think he's muted. Anyway, you go ahead.
So at the outset, I would like to thank Dr. Jignesh, Dr. Joshi, Dr. Varsha, and all the panelists here for this wonderful opportunity. I'm grateful to Maharashtra Ophthalmological Society for this huge honor and invitation. And this is a topic it's close to our heart, and many doctors who are running the practices are asking why is it necessary for our practice, how it will help us. And Dr. Jignesh asked me to list the benefits of NABH accreditation so that members can go in for the accreditation. He's been spearheading MOS in a great way. I heard this is one of the weekly programs, over 90 programs already. So thank you, Jignesh. You've been a very active and dynamic president, setting the trend for the future presidents. Going to be difficult to scale such heights. So thank you for the invitation. And so my presentation is, since it's late night, it's going to be very simple on how to understand the benefits in what perspective and how to reap the benefits of accreditation. I will not name only NABH because there are a lot of other accreditation systems, and there are so many modalities and also certain levels of accreditation. So these are the accreditation programs run by NABH, and there are accreditation programs from the ISO portal, and the familiar one is also JCI, which caters to the needs of the American and European hospitals. So there are basically three levels in accreditation. One is the certification. The second one is the entry level, what most of you are familiar with. And third level is the full accreditation. So how do we go about this? So how can accreditation help the practitioners? So basically in practice, we have the new entrants, the fresh postgraduates who want to establish practice, and they are literally clueless after the post-graduation or fellowship, because most of the energy, experience and expertise for them, it's related to studying the post-graduation, getting the certification or fellowship, and then working in the hospital where there is not much of focus on practice. The second group is the young practitioners who have some experience working in the hospitals, wanting to establish hospitals or take over the hospitals run by their family members. The third group is standalone practitioners or clinicians running their practice who want to scale up in terms of not only practice numbers but also in terms of branding, as well as rationalizing the practice structure by accreditation. And the fourth group is established practitioners who are on an expansion mode, want to open another center, want to scale up and bring in more specialties or any other associated allied sciences like opticals, as well as pharmacy and all other systems which can be part of the eye care practice. Then there are larger hospitals and corporate chain who has multiple hospitals and institutions, large NGO institutions or teaching institutions, and then the medical colleges. I will limit my talk to the top four, the new entrants or the fresh postgraduates, the young practitioner who has just started practice, the standalone practitioners or the individual practitioners who might be the crux of the group here, and then the established practitioner who are looking for some benefits, as well as with the accreditation system they can brand, improve their image, and then go on an expansion mode. To start with, you have to understand why this accreditation came into the picture. So you have to understand what is quality and patient safety. So quality in eye care is based, if we want to simplify, is basically doing the right things to the patient. So you have to understand what are the right things to the right people. So to whom? So if you are going to do a procedure or advise surgery, whom do you advise? Or if you're going to do some test, whom do you going to advise? At the right time, when you are going to advise the procedure, and doing things right first time. This is very important in reducing the errors as well as satisfying the patient. So basically, quality in eye care is nothing but quality assurance, and quality assurance is anything you do to measure or assess or improve quality. So these important aspect of quality forms the backbone of accreditation. So now comes the question, from whose point of view? Is it from the provider? So the doctors are the provider, or the hospitals are the provider of eye care services? Or is it from the recipient of eye care? That means patients and the attendants, or the government mandates, the central government, state government, or local governments. So from whose point of view quality has to be initiated? So what are our concerns with reference to quality? So basically our concern is to provide care as per our education, as per the established norms, as per the practice guidelines given by various societies and our teachers. The second part is utilization of resources. We have huge resources involved in setting up a practice. So not only the establishment cost, but also the running cost, maintenance cost, and the huge human resources cost. And we have to utilize them to sustain our practice. So this is our major concern. And third one is job satisfaction. We have to be satisfied with the final outcome we give to the patient, and also the sustainability of our practice. And on this same footing, we also have to enhance our skills, we have to improve our competence, and we also have to enhance our experience. So this is the doctor's concern or our major concern. But from the patient's point of view, their concern is totally different from our concerns. So their main concern is accessibility. How accessible is this hospital or the facility? Whether it's close to me, or whether the doctor is approachable and accessible to my needs, and whether it is affordable. This is a major problem in India, because the insurance penetration is less and the government hospitals or the government support facility is questionable. The third aspect is prompt attention. So when you reach a hospital, we consider everything as an emergency, particularly from the patient point of view. So if they have a problem for almost 2 years or 2 months, the moment they reach the hospital, it becomes an emergency for them. So what they need is prompt attention with less waiting time, early diagnosis and cure. So we have certain systems for diagnosis, confirmation, and also initiating care and cure. But all they want is early diagnosis and cure without involving the major investigations or investigative modalities. And they want to return to productivity as early as possible, and also want to be treated with empathy, respect, and concern. So the patient perception of care is not based on the doctor's perception of care, but is rather on objective measures. So patient-centeredness with clinical quality. So this is called the right care, right person every time. So this is based on this 6 important dimensions, or the key dimensions of quality. It has to be safe, the care has to be effective, it has to be patient-centered, it has to be timely, efficient, and equitable care. The third stakeholder in the entire care delivery process is the government or the society, whether it may be state government, central government, or local government. So their thing is related to the supervisory norms, how effectively the funds spent on healthcare is utilized to ensure safety of public and prevent inappropriate or suboptimal care from the providers, and to meet the requirements of the recipient at acceptable cost. It is not at the acceptable cost to the provider, but the government is more concerned about the cost to the recipient or the patients. So is it possible to keep everyone happy in this among the three stakeholders? Can we find some common grounds on this issue based on established standards or practice guidelines? This is where accreditation comes into the picture, because accreditation system builds a bridge between quality and service. From the patient point of view, quality is an emotional thing. Service is an emotional thing. From the quality point of view, is actually what happened in the care process. What was the clinical outcome? What was the visual outcome? And how the patient perceived it happen. So, for the patient, it is emotional. From the quality point of view, it is factual. So accreditation, you all know, is probably the single most important approach for improving the quality of healthcare structure. So it starts with establishing the quality systems, then the healthcare accreditation, and then with the use of the systems and accreditation, how we are going to achieve service and clinical excellence to improve patient satisfaction. So what exactly is accreditation? This is a lengthy definition. Let me simplify it for you. So basically an external peer assessment process. So these external peers are nothing but other ophthalmologists or other doctors who are in hospital administration, or maybe nurses involved in accreditation, and the administrators. And how do they assess? They assess the performance in relation to established standards. It's not something variable. All these standards are known to all the stakeholders, and also they look at the ways to improve it continuously. So basically, accreditation is an external review of quality based on written and published standards. And the reviews are conducted by professional peers. And suppose it's ophthalmic hospital, the reviews are conducted by the ophthalmologist. One of the assessors would be an ophthalmologist. And this accreditation process is administered by a third party, that is an independent body. And aim is to encourage organizational development, not to give a certificate, but the aim is to encourage the development of the hospital or the practice. So how does it help the practitioners? So basically the new entrants, the young practitioners, and the experienced practitioners. So as you all know, healthcare is a complex process, particularly from the patient's point of view. It is a very complex process. It appears the same whether the care is being provided by an optometrist or a doctor or a pharmacist or a physiotherapist, whoever it is. For them, the healthcare is almost similar in colors. So they don't really understand which process is important and how they should be part of this entire spectrum. So what accreditation does, it simplifies the entire thing, process in the hospital by structure, process, and outcome, as well as what is the input and what is the output. So which means you are classifying it so that the various stakeholders understand what is happening in the healthcare delivery system. And more importantly, the patients also understand that structure is where the care is delivered, process is how the care is delivered, and outcome is what is the outcome for them, whether they have benefited by the healthcare process or the health deteriorated because of the process where they were involved. So this is a pyramid that all of us have to understand, particularly youngsters into the hospital practice, into the eye care practice, have to understand the pyramid of healthcare delivery system starts with regulatory competence. So this is where our doctors feel that accreditation is more focused on all this paperwork, regulatory issues. So this is the base of practice in our country, and in our country, health is a state subject, so we have to comply with all the state laws. The second part is documentation. So this documentation, again, we are focused more on clinical documentation, but here in the practice, the documentation helps in improving the efficiency of our processes. The third is aspect is reducing the complaint. So patient complaint, reducing the wastage, reducing the defect, and elimination of rework. So this is important from the point of practice, because every time we do a redo, there is a lot of considerable wastage. And every time there is an error, there is considerable wastage as well as bad name to the practice. And we have to focus on this. And the last important aspect is satisfaction of the various stakeholders. So the first stakeholder is patient. They have to be satisfied. Only then they will recommend our service and our practice will grow. The second important stakeholder are the employees, not only the doctors, but also all employees in the hospital. So they have to be satisfied in the care delivery process. And the third aspect is the management who runs the hospital. It may be a solo doctor, or it may be a group practice, group of doctors, or it may be a private limited company or public limited company. So they have to be satisfied in the managing the hospitals. So accreditation helps in sorting out this by simplified approach, by a pyramid-based approach. And standards actually help to retain the safety and quality of practice. So this actually standards helps in not only going to the quality of practice, but also sustaining the quality of practice. So we'll come to the benefits of accreditation. So what are the benefits of hospital accreditations? There are major and minor benefits and multitude of tertiary benefits. Generally, we are oriented to classifying things into primary, secondary, and tertiary. The same way, the benefits here can be classified as primary benefit, secondary benefit, and tertiary benefits. So the tertiary benefits are lots. So is accreditation necessary? If it is not necessary, many of these hospital advertisements and branding images will not be there in the media or in the TV. The moment someone gets a NABH accreditation, whether it's entry level or main accreditation, what they do is put up big posters or give media advertisement that telling that this is a major achievement. So this is basically a branding exercise and also a promotion exercise. So these are some of the branding exercise done by the hospitals moment they get not only the main standard accreditation, but also entry level. They consider as a significant step in their hospital growth. So branding and marketing, it's about heartbeat and not chest beat, even though you would not consider this as a significant step, but many hospitals use this as a great branding mileage. So the major benefit of accreditation is to promote the practice, make it viable and sustainable. So once you get accredited, so there is a system in place. So the practice is sustainable, and also since we have the data and all the measurements, it is a viable practice. So what are the benefits? It enhances public confidence. So in India, this the accreditation is considered as a significant step in hospital practice. So it gives a lot of public confidence on the hospital. So it improves patient care and stimulates continuous improvement to patient care, and also encourages good governance. Many of the practitioners are not aware of the management systems, and standards provides the framework for understanding the hospital practice as well as the management of the hospital. And of course, getting this accreditation demonstrates a commitment to quality of care. So as I said earlier, it raises community confidence, it increases patient and customer satisfaction. So how does this, how does a logo or how does the image of accreditation increases customer satisfaction? Because along with accreditation, the standards are implemented, and the standards actually, one of the major standards is patient related PRE, which is nothing but communication and counseling the patients. So the communication with the patient and their attenders improves, and this ensures satisfaction. The last thing is what bothers us, a good return on investment. So many people perceive accreditation as a costly exercise. So you're spending lots on the accreditation fees, but also spending on consultancy, training the staff, and improving the infrastructure. So what is the return on investment? So let me come to this later, but there is a good return on investment over a period of time, and it also improves financial performance. Right. Now we all know why accreditation gains importance, because it's one of the important aspect of getting empaneled with all these third-party administrators and insurers. So accreditation helps in empanelment, not only this private insurers, but also government agencies like CGHS, ECHS have made accreditation as mandatory norm before sending their patients, and government is also encouraging accreditation as an important quality initiative. And how accreditation improves finances and streamlines the accounting? One is the improvement in the documentation. And as I said earlier, it improves the empanelment structure. So it's easy to get empaneled with ECHS, CGHS, now the Ayushman Bharat, the GIPSA group of insurers, as well as automatically the private insurance also empanels the hospital. The second important aspect is ECHS, CGHS gives 10 to 15% more on the cost factor for the accredited hospital. So this actually improves the financial system of the hospitals and also improves the cash outflow to the hospitals. So accreditation improves the finances and also the bottom lines for the healthcare facility. The next important aspect is benchmarking, grading the hospitals and rating. So many third-party agencies like newspaper in this case, they base their awards and also this listing or grading based on certain measurable quality indicators. So accreditation also based on measurable quality indicators. So once you start doing accreditation and also measure key performance indicators, it's easy for the management to follow the indicators and follow the growth of the hospital on various factors. So this becomes an important key performance indicators are important in benchmarking your hospital or practice for various quality awards as well as rating agencies. So Jamnal Al Bajaj, the QCI, AHP awards and many healthcare awards are based on these measurable key performance indicators. And accreditation helps the practice in scaling up. So not only the local national level empanelments like ECHS or CGHS, it also helps in empanel by other third parties, the medical tourism promoters, the corporates or the public sector enterprises like BSNL, Port Trust, Airport Authority of India, and then the angel investors. If you're going to go for funding, angel investors or the venture capitalists look for some kind of accreditation, whether it's ISO or NABH or JCI. So they look for this particular logo on your letterhead. So before they come to understanding with you for funding. So accreditation helps as well as provides access to reliable and certified information on the facilities you have, the infrastructure, the governance and the level of care you provide to your patients to all the third parties, not only government, NGOs, but also Rotary, Lion, various funding agencies as well as venture capital funds. So apart from all these benefits to the management, there are benefits to the medical and paramedical staff. This includes doctors. So the accreditation system and the standards improves professional development, provides education on consensus standards because the care is given based on the practice guidelines. It improves satisfaction with the working conditions because over a period of time, not only the infrastructure for the patients, but also the infrastructure for the doctors and the staff improves. And also good HR practices and accountability because NABH has one of the main focus on the health human resource standards. And what are the other benefits for hospital employees? It measures employee satisfaction. During every assessment, employee satisfaction is measured. And once the focus is on measuring employee satisfaction, it also helps in improving the satisfaction over a period of time. It improves employee safety and security. So there is a clear communication between the management and the staff, particularly with reference to the rights of the staff and also the responsibility. There is clear, good job description given and also follow-up appraisal every year or on a frequent basis. This actually improves the communication between the management and the staff. It aligns employee objectives to organization or the hospital objectives. So this in turn leads to energetic enthusiasm and participation of the employees in the accreditation process as well as the growth of the hospital. So basically, as you all know, accreditation is all about improving the structure and process to improve the outcomes in terms of patients as well as in terms of hospital growth and revenues. And this becomes a vicious cycle so that over a period of time, patient experience and the patient satisfaction improves. And that gives a better outcome, not only with reference to patient satisfaction and brand image of the hospital, but also the revenue uptake. And what are the benefits for patients? So there is access to a quality focused hospital for the patients. Their rights are respected and protected, and there is understandable education and communication for the patients. And these are some of the other benefits to the patients. Their satisfaction is evaluated, the involvement in care process, because there is a constant communication and counseling with the patient and the patient attenders. So there is also a constant focus on patient safety and care, and also helps them in choosing the right hospital. Patient now prefer branded care, which is certified by the third party agencies, which also takes care of the patient complaints and feedback system. So they look for accreditation symbols, and they're also now more concerned about their rights and communications. So all in day's work, patient safety is taken care of by accreditation standards, and also helps the organization to better prepare and prevent than repair and prevent by avoiding redos. So is accreditation beneficial? Yes, to all the stakeholders, patients, families, staff, the board members, directors, as well as to the community. So it helps in giving better outcomes. It increases the efficiency of the hospital. It enhances quality and safety and reduces risk on medical legal aspect and various crisis aspect. But this doesn't happen on the first accreditation. It takes a lot of time. So for the second cycle or third cycle, it is like the market. So it's not the investment that counts. It is the time and the market that counts. So same way with accreditation. So the more cycles you go with accreditation standards, the more benefits you reap. So accreditation is all in all a very powerful tool with the doctors and the management. That is a strategic and change management tool. It is a wonderful driver for improving the quality. It also gives an opportunity for rigorous analysis and audit of our services. It gives an opportunity to identify the gaps, so where we fail, where we are good at, and what needs to be improved. It also gives an opportunity to have the services recognized, where you can focus on niche area as the best in class. So benefits of accreditation for the patients, for the staff, for the management, for the government, for the payers like insurance as well as the corporate. It's a win-win situation, and it's important that we take this accreditation journey with all these benefits in mind. Thank you so much for the wonderful opportunity. To conclude, accreditation, this is a perception that I have a good practice. What value do I gain? Adds little value to my hospital. It's only for corporates and medical tourism provider. It's so difficult, not practical and costly. Why do it now? But on the other hand, the reality is accreditation is a wonderful branding and marketing and management tool for your practice. It is cost effective. It improves all business aspect of your practice, and it enhances quality and reduces the risk, including medical legal risk. Thank you so much for your kind attention.
Fantastic, Dr. Nirmal. You have actually given a very deep insight, and I'm sure majority of the individual practitioners and of course all the freshers are definitely going to take this seriously and see that they have the NABH accreditation done. Very nicely put up. All the points in such a short time. I think you have almost covered a book. So nice of you. I think we have Dr. Varsha with all the questions for you and the panelists. Over to you, Varsha.
Yes, sir. Thank you, sir, for giving us such a deep knowledge about the NABH. So we are now well versed with all the benefits to all the levels of NABH. But what about the financial burden to maintain these all the standards, sir? Because it is very much on a higher side as compared to the revenue gained by the small organization. So how to cope up with this, sir?
Okay, see, the cost of accreditation in our country is high because of three reasons. So the first component of accreditation cost is the accreditation fee that is payable to the accrediting agency, whether it's NABH or ISO or JCI or whatever accreditation. So they have certain cost for accreditation. Okay, so that includes the assessment fee, right? So maintaining the accreditation, promoting the entire accreditation system across the country, and also revising and establishing the accreditation standards. So there is a cost for it. Okay, so this is payable, and at present for eye care, it is kept at a minimal level, right, based on the number of surgeries done by the hospital. So it is not based on the beds, because in eye care it is not based on the beds. It's very difficult. So it's based on the number of procedure the organization does. So for a small organization, that is the first level. So less than 500 surgeries per year, major surgeries. So the cost is maybe we can share the cost structure, or they can go to NABH website and get the cost. So it's on 4 levels: less than 500 per year, 500 to 1500 surgeries per year, then 1500 to 5000, then beyond 5000. So it's basically based on the scope of services and how big the organization is. So this cost should not be a dampening factor. So that is our concern, and that's what we looked at when we established the eye care standards. The second aspect of cost is the infrastructure cost and the license cost. So this is basically needed for the hospitals, right? So license is mandatory, and of course in our country, because of the difficult licensing process, it's not only the licensing fee, it is the cost to get that licenses and also maintain that licenses every year. So this we have to work with the association level or with the government level to reduce the rate, frequency of license, or reduce the licensing fee, and also optimize the requirement for licenses. So this IMA did recently for pollution control board license. For previously we have to get it every year. Now with the help of IMA, they changed to every 3 years, and now small hospitals can apply for 5+5, even 10 years. So that means the cost of licensing also comes down. So likewise, we have to work with the association to reduce the cost of licenses. The third part is the cost of infrastructure. So many of our hospital, we just start as clinic and then we expand our services, right? So there is a staggered development. So there are certain infrastructure deficiencies, so that is needed for accreditation. So the cost when they go for accreditation, this deficiency cost also added to the accreditation cost. That's why we perceive it as very costly. And then the training part, training our people, training the people, because accreditation is not in our curriculum, neither in the doctor's curriculum nor in the nursing or the administrator's curriculum. So that we have to work over a period of time, and now the new curriculum focus on accreditation also. So people coming out of this new curriculum will be definitely oriented towards accreditation standards. So that cost can reduce. But anyway, any institution have to spend some cost on training. So that is actually the cost of maintaining the hospital as well as cost of training the workforce. So that you have to spend to improve the cost of quality as well as giving quality treatment to the patients. So you can't mix all the cost and put it as accreditation cost. The accreditation cost is put in the website. So that is the cost. So generally hospital take the consultancy cost, the training cost, the infrastructure cost, everything put together under one costing. So this is the perceived increase in accreditation fee, accreditation cost. Any inputs from Gagan?
Sorry to.
Totally agree, sir.
Who decides the? Gagan. Sorry.
Yeah,
Gagan
just we'll add because sir said. So I'll just add one thing, sir. The minimum for less than 500 surgery application fee is 10,000, and the annual fee is 50,000 rupees.
Okay.
Okay. But who fixes
That
this?
actually covers, I believe, when we did the standards, about 90% plus hospitals fall into this category.
Okay, Dr. Gagan and Dr. Nirmal, who fixes this fees? Is it the government agency, the government, or the NABH accreditation agency?
The accreditation cost is fixed by the Quality Council of India, so which is mandated and approved by the Government of India.
Okay. Oh, that's
The
nice.
cost
Yeah,
is very
you were
high.
speaking something, I interrupted. Sorry for that. Yeah, Dr. Kumaran.
The cost is very high because most of us seek an external help to get accredited. And that is the major cost. So when you are able to do it yourself, I think the cost would drop down 80 to 90%.
Okay.
So I think, see, we learn a lot of difficult surgeries. I think learning to get accredited by ourselves is also important. And it is not difficult. See, there's a guidebook available. So I think every doctor has to just follow the guidebook and just go through it.
Dr. Kumar, I'm sorry to interrupt. Your voice is very, very low. Yours and Gagan. I think Dr. Nirmal has got absolutely perfect voice. Rest of them can hear.
Okay,
Speak a
so
little loudly
Come
because
closer to the
talking
mic,
hearing.
Kumaran.
yeah. So just to add to that, we all have had experience, including when our colleagues, our juniors, and our friends have gone for accreditation. See, first thing is, you should know what is required. So many a time, external consultants tell them to do many a things which are not required. Like a worst case scenario, a person was made to rebuild his OT at a substantial cost, and you could not operate for a month or two, time over and something. Whereas for entry level, there was no point in renovating the OT; it was not required. So many a time, whenever we, like, if I want to buy any small thing, if I want to buy a mobile, ask two people. It's just a cheap thing. Yeah, this one is good or not. The same thing with NABH. Sometimes we are so busy with our practice, and we just have that mindset: I'll just spend this money and get over with it, and we end up actually wasting money. So, whenever you're, planning to spend a substantial amount of money, do a due diligence, because these are, like, I can give very, very big practitioners who are very much senior to me, and, they have ended up, changing their hospital and doing things which were not really required. And that adds to a substantial cost, which can be avoided. So we do a due diligence for even $1,000, but here for lakhs, sometimes people just listen to an external consultant, go ahead and do with that. So whenever you are spending a major chunk, please do a due diligence. It's your hard-earned money. That's all I would like to add.
Quite right. So nicely put up. Yes, Varsha?
Yes, sir. Why the documentation or evidence-based practice is more focused by NABH rather than applicable standards? Like, why there is so much documentation is required for NABH?
Okay. Gagan, you want to take this question?
Okay, so in a generic way, let us say that we have been under-documenting things and getting away with it. The whole thing is, let us take NABH out of equation, and there are plenty of things in AIOS also, and everyone in MOS. Take into account your medical legal requirement or your legal requirement of maintaining the record. That's what NABH emphasizes, and NABH takes from there. So if you take into that account, I don't think so there is any edit documentation majorly required. It's a minimum documentation which we are required to do as per law, right? So NABH only puts a focus in checking whether you are doing it or not. So let me again just put it in an example. I'll take a simple thing: consent form. See, when I started working, our consent form was half a page, and top will be English and bottom half will be Kannada. Later on it became one page. NABH came, it became 2 page. Right now it's almost 6 page in one language. Okay, but we would have anyways revised those consent form even with or without NABH as per the things have been evolving. All those things. The same thing goes for other things like our OT notes we would have been documenting in a very short form. Now we have had enough notices and court cases to know that we have to document it in a little bigger manner. So all in all, I believe that the documentation requirement from NABH stems from what our law says and what the Medical Council of India says. Probably we have been getting away with not doing it. So that is the clinical part where the documentation is involved. In addition, yes, to maintain standard, as Sir told, and he also told you the reason that you need to have some KPIs and you need to have some meetings and you need to have some quality improvement program. That's an additional documentation, but then without documentation, those things will not take place. How do we know we have had something and what is the outcome? But those are good practices which are coming, and they are also helping. As I told all those things in quality improvement part. So that quality improvement again will add that documentation, but then we also have the benefit with that.
Right.
Yes. I would like to ask Suchita ma'am, Just if what is the loss if we don't get the accreditation, but we can still maintain the quality standard for the patient? What is the loss?
So, thank you, Varsha. Let me, am I audible?
Yes,
Yeah,
ma'am.
yeah.
Yes, ma'am.
Yes, please.
You are clearly audible.
We start by complimenting Dr. Frederick for a very wonderful presentation. Sir, you are
Thank
like
you.
a living India for NABH accreditation. Okay, let me now get back to the question that you asked. What if there is no accreditation? Can we still maintain the quality? Is that what you asked? So just now we discussed that NABH accreditation is like a stamp on the quality of services that you are providing, which also helps in building your own brand. So I would say, even though it is not legally mandatory at this point of time, this is going to become a necessity. Actually, is has become a necessity at current point of time because now it doesn't help only for branding, but also helps for other things such as insurance empanelment and for large organizations to get to attract donors and international NGOs, and for individual practitioners, very soon it is going to become as common as ISO certification. So even patients are likely to ask in your future to the doctor whether your hospital is NABH accredited or not. So that makes it a very sensible decision to go for NABH accreditation even for individual practice. Yeah,
Right, right.
thank you.
Ma'am. Thank you, ma'am.
Yeah, sorry, the question was not for me, but just would like to share something.
Sure, sir.
So one thing is, I can just take an example of two of our fellows who have started their practice, and they have done the way you have told. They have put in, their systems and their paperwork and things in practice from day one. And the good thing about that is that when you're starting practice, you may not need NABH from day one. Probably you are also testing what are there many other places where you want to focus your energy and money. But if you maintain the standards, the day you feel that NABH is going to add on to your practice or the day you are ready, your transition will be very smooth.
Yes.
So as you said, it's actually a very right way of trying to maintain the standards in our practice and also try to align with them, with the JCI or NABH standard or whatever is prevalent, any state standards. So whenever the time comes, your transition will be very, very easy, less painful. And other thing we are talking about expense, the expenses also will not be there because we have maintained everything.
Now, that's what I also advise the young practitioners who are going to start. So when most of them come at the last minute to help with the design of the operation theatre or how to run the practice, whether get EMR straight away, whether establish all these things in the beginning itself. But generally, it's very easy to design a structure even before you plan or start the hospital building. So it's always important that we incorporate the infrastructure requirement beforehand. And so NABH or any infrastructure requirement is given by the law as per the legal mandate. And second, as per the scope of services, what are services they're going to provide, and as per that, they have to design the structure. The same way process, whether to use EMR initially or the manual documentation, and then once they reach a stage, then switch over to EMR. So all these are important decisions to be taken by the practitioners. So they have to know all these things. So in that way, standards help. So even before starting the practice, if they can download the standard, which is available free of cost in NABH website, that gives a orientation on how to set the practice. Okay, we learn so many things in ophthalmology, some new things. Every 2 years, there are some new things, and we spend a lot of time, energy, and also we spend a lot of our money on learning new things. Same way, these are some important things that really help in establishing the practice and running the practice safely.
And sir, you have told us about the entry level accreditation and full accreditation. So what is the difference between that two? And how long we can go for the entry level, sir?
Okay, so entry level is basically a certification. So I've told you 3 levels. One is the entry level. So this is entry level for small healthcare organization. Then there is a progressive level. At present, it is not there. It's just a step ahead towards full accreditation. The certification is valid. The certification standards are very limited. are very basic and doesn't cover all aspect of practice or care delivery system. Whereas the accreditation standards cover the entire gamut of eye care practice. So there is a difference in the number of standards and number of objective elements, both for certification and accreditation. So certification is valid for 2 years. It can, at present, NABH policies, it can be renewed for one more term. Accreditation is valid for 3 years. It has to be, the organization has to go for re-accreditation after the end of 3 years.
What do you recommend for the individual practitioners? Entry level, or they should go for a full accreditation?
Now, since we have our specialty specific accreditation standards, it is always better to go for eye care organization standards because entry level may not be specific for ophthalmology. It is specific for small healthcare organization. The fee structure might be different, but it makes sense to start with eye care standards itself. Or if they've already got for insurance needs, they're already in entry level, so they can slowly shift towards eye care standards and go towards specialty specific standards.
How much time does it require to shift from the entry level to the full accreditation?
There is no time limit given by NABH. It's just the implementation of the different standards. So certification standards, as I said, the numbers are less, whereas accreditation standards, the numbers are slightly more. So we need some time to implement those standards. So first we have to do a gap analysis. What is the gap in the practice, so with reference to the eye care standards, and you have to based on the gap analysis, you have to have a timeline in implementing those deficiencies. So generally, organizations take about 3 to 6 months from entry level to eye care standards.
Very good. Yes, Varsha.
Sir, does the continuous surveillance option is given in NABH instead of re-accreditation?
Can you rephrase your question? So the accreditation is like this. Once accreditation is given, after pre-assessment and final assessment, it is maintained for 3 years. In between, there will be a surveillance assessment. So at the end of 18 months. So that is between the, so midway between the 3 years.
Okay.
So after the surveillance assessment, there will be a re-accreditation. So at the end of 3 years.
Okay, thank you, sir. So there are the eye care organization standard. So how it differs from the NABH standard? Does it have any difference?
I think Gagan would be the right person to answer. Yeah, he would have the numbers. See, in eye care standards, it is only ophthalmology specific standards. The main standard is generic for all specialties and multi-speciality hospital. So our hospitals found it very difficult to implement the main standard. So now it is 5th edition standards. So there were a lot of other specialty standards also. So eye hospitals found it difficult to implement them. So that is where AOS and NABH came together and started the work on eye care standards in 6 years back, the 2015 to be precise. So 5 members from All India Ophthalmic Society and 5 members from NABH formed the technical committee for establishing the eye care standards. So we worked on the standards for almost over 9 meetings and 1 year. And we took only ophthalmology specific standards from the main standards and made it into eye care standards. So there's a lot of differences in the number of standards, say 516 for the 5th edition, and whereas eye care will have only 305 objectives. The 10 chapters remain the same, but the number of standards and the objective element is considerably less. Maybe Gagan can share the exact numbers.
Number of
Yeah, I think
hospitals
270.
or standard?
Yeah, standards and objective elements in eye care compared to 5th edition.
Almost less than half, 305 or 6 for eye care, and 5th edition goes to some 680 or something. So it's virtually less than half, about 40-45%.
Oh. That's good. Yes, Varsha.
And yes, sir, how can we do the clinical audits? And what are the personnel involved in this? And how can we train them to do our internal audits to maintain the continuous surveillance?
Okay, so internal audit, we have to train our own people. So basically, when we start the work on implementation, we have to identify few people from each department, and we have to make it into a team, quality team. And there will be a head for the quality team known as quality coordinator, or we can give various nomenclatures. So this quality coordinator should be proficient with NABH standards. You should be experienced with clinical work as well as the documentation work and the administrative work. You should have control over the staff so that he can audit and also administer the group of people. So this quality team would be the first internal audit team. So they will be proficient with NABH standard as well as the methods of auditing. There are various methods of auditing, vertical assessment and horizontal assessment. So we have to train these people into assessment of or periodic assessment of the services. They may be doing only department level audit, or they may be doing the entire hospital level audit. So based on their experience, expertise and the qualification, so they have to be assigned as internal auditors. So there is a set system for training your internal auditors. There are various courses given by even NABH runs courses for this is called program of implementation or internal auditors training. The hospitals can send their workforce, identified staff to NABH or Quality Council of India. There are online as well as offline courses. There are various other courses run by organization called CAHO, Consortium of Accredited Healthcare Organizations, and also the accredited hospitals themselves, like Center for Quality Promotions are there. There are about 15, 16 hospitals. They are also running internal auditors course. Once you identify people who can help, who can be passionate about implementing quality in the hospitals, we can train them and they will in turn do the internal audit.
And sir, how often should we carry out these audits?
It depends on the size of the hospital and the scope of services. Ideal is every 3 to 4 months. There are some hospitals they do it every 6 months. But the more the critical nature of the facility, maybe for in our hospital, the infection control audit is done every month. Safety audit is done every month, whereas other HR and MRD audit all done every 3 months. So it depends on the criticality of the service.
So the NAPA standard has been revised for the fifth standard. So what are the major changes in that fifth standard, sir?
See, fifth edition standard may not be applicable to eye care hospitals. Since our major scope is eye care hospital, it's not prudent to discuss here. But a lot of changes from the fourth edition. So new things have been incorporated. For example, telemedicine standards have been incorporated. Green hospital standards have been incorporated. The major changes to the biomedical wastage that has been incorporated. And in ophthalmology, I think we have, with reference to eye care standards, we have incorporated the policy or standards on reuse of devices. So there were in ophthalmology, we use a lot of reuse of devices like PECO, tubings, consumables, all those things. So we brought in a new standard for that. Same way, sharing of consumables to reduce the cost to make it affordable. We brought in a new standard for sharing of consumables. So these are things that have been specific for eye care standards.
Dr. Kumar, would you like to add anything? I think he is quite quiet. Nirmal is answering majority, he is not getting involved.
Oh, no.
Dr. Kumaran?
Yeah. See, Dr. Nirmal's talk was very lengthy, and it was covered all the salient points. And I think he's the right person to talk on all these accreditations. So I would be happy to listen to him as for now.
Sir, I would like to ask one question to Kumaran, sir.
Yes.
So in the fifth edition, there has been emphasis given on the core commitment and achievement excellence. What is exactly?
Sorry, could you please repeat that question?
Am I audible, sir?
Yes, you're audible.
Yeah, you are audible.
Yeah,
Dr.
yeah.
Kumaran is not. Dr. Kumaran, you'll have to raise your voice.
So am I audible, sir?
Yeah,
Yes,
much
sir.
better
Yes,
now.
yes, Kumaran.
Now
Yes.
you're
Please
audible.
go ahead. It's your turn now.
Yeah,
So,
but please
as
repeat
per
that question.
yes, sir. So, as per the fifth edition, the emphasis has been given on the core commitment and achievement excellence. So, what exactly it is, sir? Just we want to know it.
So I think Dr. Nirmal or Gagan would be the right person to answer this because I'm not very well versed with the fifth edition as for now.
Yeah, Dr. Gagan. Gagan, you have to unmute.
Yeah.
Dr.
Gagan,
Gagan.
unmute.
As Dr. Nirmal told, fifth edition will actually be digressing from what is our core here, but just to put it in one or two lines, see what has happened is there is a scoring pattern. So that scoring pattern has been changed with fifth edition, and along with that scoring pattern change, the elements have been divided. So for every standard, the core element which you will find mentioned there is mandatory. So every time that element has to be checked and you have to attain. It's like compulsory for you. It becomes a fixed line there. And then you would obviously afterwards have commitment standards, and then you would have your achievement standards. So the commitment standards again are mandatory, but the scoring will be like old standards, so you will still get a scope of improvement over there. Whereas the achievement standards are like those bonus marks. So ultimately an organization would progress beyond that. So that will be the achievement standard, which is an aim beyond these standards, but it will not be mandatory. The whole thing will come up with the scoring. I think so. Fifth edition is not of any use to us until unless we are in a multi-specialty hospital. Standalone eye practitioners, only two standards which are relevant to us would be the entry-level standards and eye care.
Right.
Thank you, sir. Thank you very much.
Yeah. Varsha, any more questions?
No, sir. I'm done.
Okay. I would like to have Dr. Kumaran to give the farewell message or the go home message for the individual practitioners. What you would like to say? Each one of you have to say. We'll end up with Dr. Nirmal in between Dr. Gagan also and Dr. Sucheta can speak.
Okay. So see, NABH is here to stay. See, whether we like it or not, whatever level of practice you are in, it has become mandatory now. It is not only for the care of the patient, but when you take care of the patients, obviously the doctor is also safe, and everyone it is safe. And it is also become a marketing tool now because see, every hospital start advertising in social media, and having an NABH accreditation to your hospital adds more weight to you. It not only increases the care for the patients, but also you are also safe, isn't it? So that is the way to go. And my personal experience with NABH accreditation, and now we are the third or fourth year of accreditation. Initially, we did take an help from an external agency, but then the second and third time, we didn't go for an external agency. We just involved all our staff, and then we try to do it ourselves. And I think that is the way forward. We as doctors spend a lot of time in training ourselves to all new kind of surgeries, letting know all the new machines which come in. So I think similarly, you should be interested to learn all the new accreditation techniques, and then inform them to your staff and do it yourself. And once you do it yourself, the cost would really come down, and you love what you do, then it becomes very easy. So the thing point is, the ending point is whether you like it or not, you really have to go into it. And I think you have to like it and do it. That is my advice to all young ophthalmologists who are starting their practice. And try to get, know all the standards and try to implement everything in the beginning itself. Don't just go for a pass mark. See, when you go for an exam, we never aim for the pass mark, isn't it? We want a center or everything. Similarly, know all the standards and try to implement at least the minimum at the end. Thank you.
So nice. Yeah, Dr. Gagan, you can unmute and speak.
Yes, something really, because we had lots of discussion on financial, I'll make a very debatable statement. But the fact is, if you look at any industry, if the input cost goes up, you increase the prices. So here, we are, I don't know, in ophthalmology compared to other specialties, why we focus on trying to cut costs and trying to, make ourselves more into trouble. So somewhere down the line, isn't it good that we consider NABH is a required cost of our business or our practice, and try to, get that cost in the remuneration which we charge. So if our remuneration goes up, these all costs will not pinch us. So, that is something which is a very debatable, but yes, I believe that with changing circumstances, ophthalmology services are priced at quite a low level where there is a scope of substantial increase. And I would like to compare it with other specialties. So if I see my colleagues in other specialty, they definitely have better margins and definitely charge more. So, if we can somehow get more for our services, these NABH charges will not pinch us.
Quite right. Suchita, now that HV Desai is already an NABH accredited, your view for the individual practitioners. Dr. Sucheta, is she there?
Ma'am,
Yeah,
please
she is there.
unmute.
You need to
Unmute yourself.
unmute.
Ma'am,
Unmute,
please
please.
unmute yourself.
Sorry, sorry. Am I audible now? Yeah.
Yeah.
So my message for the beginners or the individual practitioners who are about to start thinking about NABH would be, each one of us has to go through a state of confusion when we start working towards NABH, and sometimes we do feel inadequate and utterly confused while implementing or understanding those processes, but it does pay off in the end, and slowly the NABH culture is becomes a part of your DNA, and then it becomes like a cakewalk. So don't feel what I say. Don't feel depressed if you are feeling confused and inadequate while starting the process or while undergoing that process. But just persist, and you will get there. Thank you.
Thanks, Sucheta. Dr. Nirmal, specific questions to you now that you are already into this and you're the
Yes,
boss
Jignesh.
around. Yeah. So I would like to ask you 2, 3 questions. One is very important. A person who is an initial practitioner, he's put in money and he's got a entry level accreditation. And as you said, over a period of 6 months to 1 year, he gets it. And the renewal is after 3 years. Now, suppose he has already achieved that level. Do you still feel he needs to renew again and again? Or can he now, once that he has set the standards, can you continue doing with it? What is your advice, frank advice to all the beginners who are going in for this?
No, basically, accreditation is a continuous process.
Hmm.
Quality is a continuous process. So you can't switch off. It's like a journey, right? In between, you can't switch off your engine. You have to move forward. So you
No,
have.
no, no. The specific question is they have an internal audit, the way Varsha asked you. If the internal auditor and the external auditor matches with what his performance is, they do a
Okay.
regular internal auditing and they do a self-improvement process once the actual accreditation has been got. Why I'm asking you, the input cost and the renewal cost, as you said, is high initially, but on a continuous, what do we say, on renewal also, it is the same cost or there is cut down in the cost? That is another question, a corollary to that.
Okay. So the cost of accreditation, the annual fee is the same. Whether you go for second renewal or reassessment or reaccreditation, it is the same. There is no change in the fee structure. But your the implementation cost will not be there for the second cycle. Like Dr. Kumaran said, the hospital themselves have to do it. The
Yeah,
practitioners have to get involved. So once the doctor gets involved, it is easy for the team to fall in line. The running cost of implementation comes down, and over a period of time, the team became passionate in implementing them. So there's a lot of learning, not only with reference to improving the patient satisfaction as well as the outcomes, the practice outlook also changes. So you focus on what is really needed for the practice. So you tend to cut unnecessary expenses. So
right.
the cost can be cut down like this. So
Yeah,
reducing the wastage and also improving the proficiency and efficiency of the workforce.
perfect. I think you have put it so rightly. Yeah, everybody now, I'm sure, who's listening today or who's going to, because we'll be uploading it on the YouTube, perpetual for people to see. Such a nice talk, very nicely covered. All the panel discussion was so informative. I'm sure each and every MOS member and the ophthalmic fraternity, especially the new members, are really going to take it up for themselves to see that they are NABH accredited because they've seen the benefits which Dr. Nirmal and all the panelists have spoken about. A big thank you to each one of you. Varsha, you have really conducted it very nice. You have tried to get maximum out of our expert panelists.
Thank you, sir.
Dr. Nirmal Frederick, an excellent talk as usual. I've been seeing you right from so many years. It's always absolutely to the point. Whatever we have asked for, you try and cover that very nicely. Dr. Kumaran, Dr. Gagan, of course, you are the icing on the cake. And Dr. Sucheta, our in-house consultant, and she knows about the intricacies of the NABH. Very nice inputs from each one of you. So, big thank you to all of you for joining and making it so lively and informative. I would like our Honorary Secretary, Dr. Rajesh Joshi, to give a vote of thanks. And before that, we'll have a gallery view picture for each one of us for posterity. So let's have the video on for each one of us. And Syed, can
Yes,
you
sir.
have the click and then you can play your video, 1 minute video of Entored, and then we have the vote of thanks,
Sure, sir.
official vote
Sure,
of
sir.
thanks. Yes, sir, yes. Can we have the gallery view photo before Dr. Joshi can give the vote of thanks?
Yes, done, sir.
Done? Okay, thanks a lot. Yeah, Rajesh, over to you.
So please unmute yourself. Joshi sir, please unmute yourself.
Yeah. There was request from MOS members for having webinar on hospital accreditation. I hope all the queries have been answered and things are crystal clear. Thank you, Dr. Nirmal, for spending your valuable time and clearing all the doubts and explaining the nitty-gritties of accreditation. You had answer to all the queries. You are walking Wikipedia of accreditation, I suppose. I also take this opportunity to thank Dr. Gagan, Dr. Kumaran, Dr. Suchita Madam for their valuable inputs during the discussion. Thank you, Dr. Varsha, for conducting the session so well. I am also thankful to all those who have joined on virtual platform for today's webinar. Thanks to Entored for the technical support, and of course, Dr. Taswala sir for the wonderful initiative. Thank you all and good night.
Thank you.
Thank you, each one.
Thank you, Dr. Jignesh.
Can we have the
Dr.
recording
Joshi.
off now?
Thank you very much.
Thank you, sir.